Hi, everyone. Thank you so much for joining the Genetics Policy Hub webinar series. We are 1 minute until 12 p.m. on the East Coast, so we'll just give it one more minute and then we'll get started. Thank you for joining. Hi, everyone. My name is Megan Lyon, and I'm thrilled to welcome you to the first of our Genetics Policy Hub webinar series. I see that we have about 60 people on the call, which is great. And we will get started as it is 12 o'clock on the East Coast. A couple of housekeeping things. Everyone is muted at the moment while we go through our presentation, but please feel free to chat us any questions or thoughts you have along the way. And at the end, we'll have time for question and answers, and you'll be able to unmute and ask your question to myself or my other co-presenter, Dr. Rani Singh. And so with that, I'm thrilled to be kicking off our webinar series about medical foods coverage in April of 2023. And I'm ecstatic to have our Southeast Regional Genetics Network Project Director, Dr. Rani Singh, as my co-presenter during this webinar. This project is supported by the Health Resources and Services Administration, and so we're very thankful of their support. As I said, I'm Megan Lyon. I am the co-project director of the National Coordinating Center for the Regional Genetics Networks, otherwise known as NCC. And NCC is the one that has the Genetics Policy Hub as one of our initiatives. So I'm thrilled to be speaking with you all today about what we have in the Genetics Policy Hub related to medical foods, along with Dr. Rani Singh, who not only can give us wonderful context for what medical foods is and what coverage of medical foods looks like, but what the policy implications are of medical foods at both a local level and at a national level. So for today's webinar, we hope that by attending the webinar, you'll be able to describe the importance of why medical foods coverage is needed, identify current policies that are either currently proposed or enacted throughout the United States, and apply lessons learned to understand how you can improve medical foods coverage in your work. And so today we'll be splitting up the webinar into 3 different parts. The first is a basic understanding of medical foods coverage, which Dr. Singh will cover. Then I will get back on and talk about what we have within the Genetics Policy Hub and give you really a national level look at medical foods coverage. And then Dr. Singh will talk about her work to improve access to medical foods coverage and the work she's done in terms of policy implications for medical foods coverage, and then we will have a question and answer session. And with that, I will turn it over to Dr. Singh to kick us off. Thank you so much.
All right. Let me get myself here. Megan, thank you so much. And I do appreciate this opportunity very much to represent CERN and Emory and my experience with this in this area. And I welcome all our attendees today. And I'm sure that there's a lot for us to discuss today. So having said that, I'll start off with the definition, which most of you know what a medical food is. In 1988, this is the medical food definition by as orphan drug amendment. And the food that is formulated to be consumed or administered enterally And the key thing is here under the supervision of a physician and intended for the specific dietary management of a disease or a condition, for which distinctive nutritional requirements based on recognized scientific principles are established by medical evaluation. So there is some vagueness in this, but nevertheless, this is the most recent definition of medical foods, what we go by. Just a reminder to all of us, it was fascinating to me to realize that these medical foods were classified as drugs from 1958 to 1972. And because there were several, the usefulness was widely accepted, and they were very limited in number. And also the goal was to make them less costly to develop and add more variety by Orphan Drug Act amendments created and defined this category to the next step they did was foods for special dietary use in 1972. And then came the definition of medical foods separate from drugs and yet associated with disease. So that's where we stand. But then in 1990 and 1993, there was a little more activity with Nutritional Labeling and Education Act identifying 5 different criteria to qualify as medical food. And I listed those here. Next, please. So like I indicated, the definition of medical foods, it narrowly constrains the types of products that fit within this category. And so it's a little bit challenging how we interpret this. And in order for the clarification, then in May 13th, 2016, there was a medical food guidance released. And this is a nice little document about frequently asked questions about medical foods stated, these are stated as non-binding recommendation. They're easy to read, question and answer form. They provide information and little further clarification of medical foods and the type of diseases and some label statements. Next, please. So these are so now the medical foods they stand between food which supplies nutrients and the drugs which prevent, treats, cures, or mitigates a disease. So what has happened is there is blurring this line between food and health now. You know, the food is used to mitigate a disorder. And so therefore the therapeutic potential of medical foods is established. And that's been great advancement in the field of nutrition. But and along with it, it has generated valuable insights in the complex and dynamic transition from health to disease. How do these things change? The food is, how can food be used to manage the disease? So we are moving forward with this thought as we move the field of nutrition into this century. Next, please. So here here is a patient in Georgia. This is a Georgia patient who was not treated before the newborn screening was started. And then on the right, you see the patients who are treated. And many dietitians are in this section, don't need for me to tell them this, how the life of PKU has changed and how they can attend college and the outcomes and functionality can be improved. But in addition to achieve these outcomes, I want to remind other colleagues of ours that many other disorders that have emerged that we manage using the same principles, if you look on like MSUD, organic acidemias, they require way more other than the medical food access. They need a trained workforce to say how this prescription needs to be created. Even though it's under the supervision of a physician, the dietitians need to create the prescription based on the weight, growth, and these have to be the biochemical markers, and these have to be constantly changed by the trained dietitian. So these, if we do not have access to these medical foods at any stage, they can result in morbidity. And for some patients, that means even death, like in MSUD or organic acidemias. So we know that we have already shown that the medical food works to help mitigate these disorders. Next, please. So we also have recognized, you can click next, Megan, that there's a better survival and reduced mortality from previously lethal and debilitating conditions. That means greater numbers are transitioning to health, adulthood as functioning adults. They're having better quality of life, getting married, having families. And once these conditions are thought to be contraindicated, that the pregnancy cannot be successful, now we have several accumulating reports of successful pregnancies in a wide range of IEMs other than PKU. But and we need to kind of continue learning those from each other, how the other pregnancies other than PKU impact the outcomes. But what we have learned from PKU story is, if we do not treat at conception and during gestation, these are associated with poor reproductive outcomes. So medical food is so important. And because if they do not have access, these can result in intrauterine growth retardation, congenital anomalies, severe incompatible with life. Those are very common outcomes. And these are associated with the lack of fee control. So I have seen many women who fight these insurance issues and did not have access, and they just come out during pregnancy and tell us that they are pregnant with high levels. So I always wonder, would we negate the effects of newborn screening if we don't take care of these women, because each one of them can produce more than one child, even if they don't have PKU or genetic disorders, to produce some developmentally delayed children. So access to medical foods is very critical during that time. Next, please. So based on this premise of the success of utilization of medical foods and PKU as an exemplar, we know that many disorders were added to the RUSP panel, or Recommended Uniform Standard Panel, that required access to medical food and a trained registered dietitian. And what did we learn? That the outcome of these children is just not dependent on early screening and diagnosis, but the rapidity and quality of intervention with what we work. I can particularly personally vouch for you for last 30 years, that the impact it has if we get that medical food and treatment going for the child right away versus waiting few days or even months that can result in some negative consequences. So next, please. So this is, I want to thank my friend Helen McCune. She should have won an award for the slide. This tells a big story. If you look on the right-hand side, a typical diet, what we serve a patient, has three major components: medical food, which provides 70 to 80% of their nutrients and protein needs for patients like PKU or other metabolic disorders. And then the second part is that they have low protein modified foods, which are used as a source of energy to make up for the calories. And the third component, which is very little, is the natural foods like you and I eat. So if you look on the plate on the left side, if the patient did not have low protein modified food and medical food, and had a classic PKU, this is how their lunch meal would look like, on about 300 to 400 milligrams of phenylalanine a day. So again, the importance of reliance on medical food as a nutrient, and food as a source of mitigating a disease. Next, please. So I want to again say that once we have a positive newborn screen, childs need different foods to survive. as traditional foods can harm the child. And medical food caters to people identified with inherited metabolic disorder to survive and improve outcomes, and they are not optional. I always get in there, and it's been at least 5 decades. In JAMA, 50 years ago, we showed that all this works. And it's about half a century that these are preventative and they are needed. So I always question, why are they not available to our patients? And I also, one of the words that always touch my heart, one mom asked me, I can't afford this formula. The insurance was giving the hard time. And she says, this is food for my child. Even if I have to sell my car or a house, I'm going to do it because I need to feed my child. And this is how desperate some parents have felt if they cannot have access to medical food once their child is diagnosed. So I want to say that we know now that the primary recognized therapy for many inherited metabolic disorders identified on newborn screening. And clinically, we can reduce the morbidity and mortality and improve outcomes. It's have a half a century history of use. They're lower cost than drugs. So why aren't they accessible to all patients of all ages? And with that opening remarks, I will pass this back to Megan to share some of the challenges we face and how the policy currently stands on this topic. Megan.
Thank you. Thank you so much, Dr. Singh. And that gives us a really good context for why this is such an important policy issue for us to be tracking. And so for those of you who are not aware of Genetics Policy Hub or NCC, we want to give you a little bit of background before we get into what we are looking at in terms of medical foods coverage in the Genetics Policy Hub. And so as I said when I was introducing myself, I work for the National Coordinating Center for the Regional Genetics Networks. We are a federally funded program along with the 7 regional genetics networks, which Dr. Singh is project director of our CERN region, as well as the National Genetics Education and Family Support Center. All 9 organizations work together to improve access to genetic services for underserved populations. And so we do that in a variety of ways. Some of those I've highlighted on the slide, which range from genetics and genomics education activities, such as things you'll hear about that CERN is doing later on in the presentation in terms of medical foods. It could be something specific to a specific genetic condition or something more broad. The regions also focus on improving access to services via telemedicine, or we call telegenetics. Family engagement and partnership is an integral part of our system, and engaging those who have genetic conditions or at risk for genetic conditions to understand what their needs are. And then finally, NCC also has a focus on policy, which is where our genetics policy work comes into play. So this work began for us really a number of years ago with the passage of the Affordable Care Act. So once the Affordable Care Act was passed into law, HRSA, our funders, came to NCC and the regional system to really begin to develop specific resources around policy to help support the delivery of genetic services. And so I'll stop here and clarify that what our system really focuses on is getting access to services. And so there are other components of genetics that are vitally important, but we're really looking at that delivery between patient and provider. And so in 2015, NCC held a meeting with a large group of partners to identify really what were the policy issues and what resources were needed to better understand the policy landscape. Because we are federally funded, NCC is not positioned to advocate for certain policies or to really say we should go this direction versus that direction when it comes to policy. So we were really looking at this through the lens of what policy resources are needed for you all as providers, as public health professionals, as families, to understand what's happening in genetics and how that affects the delivery of care. And so through those, through the development of that meeting and through projects that we developed, in 2017, HRSA specifically enumerated two objectives for NCC to accomplish, and those are really to look at monitoring, analyzing, and tracking of national policy issues that, again, relate to the delivery of genetics with a specific focus on finance and insurance coverage, workforce, and emerging issues. We are also tasked with disseminating information on practices, policies, and resources related to the genetic service system. And so we have been doing this work obviously for a number of years. We've had some of these tools, which I'll talk about in a little bit, for a number of years, but everything was in disparate systems. So if you were, say, interested in medical foods coverage, in one resource versus another, you couldn't find that information. So we were very fortunate last year to be able to launch the Genetics Policy Hub webinar. Genetics Policy Hub website. And so this is a website that you can go to today to access all of our information. And it's a fully searchable website where you can type in, say, medical foods and find everything we have related to medical foods. And so for the rest of my presentation, I'll be focusing on the tools that we have within the Genetics Policy Hub that are related specifically to medical foods and what data we're seeing. I will caution that this data is always evolving. So this data was pulled last week. That does not mean this is exactly the data you will see if you went into the Policy Hub today, because there are things that are constantly evolving from Medicaid programs to legislation. And so this is a snapshot in time of what we're seeing in terms of medical foods coverage across the United States. So the first resource we have within the hub is our Medicaid database. So this database is something that we update annually, and we look at all written policies related to genetic service delivery. And so we specifically look at policies related to medical foods because, as Dr. Singh exemplified at the beginning of this presentation, it is a crucial policy arm for genetics. And so we specifically look to see what policies Medicaid programs say they cover or say they do not cover related to medical foods. And so in our 2022 update, which is on the website currently, 81% of Medicaid programs say they have some sort of coverage related to medical foods. There's some sort of determination they make related to medical foods. And so this includes both state programs and territory programs. So we pull the 50 states and 4 territories. So this is both states and territories. And so what we find is policies range from medical things related to medical necessity to who is actually covered. So coverage can be specified by a certain genetic condition, by your age, if someone is considered an EPSDT eligible child. So it really gives you a range. When you look at the data and you look at your state specifically, you can see the range and policy. And so I wanted to highlight 2 different states. This is just, there are a lot of different policies, and you can go. Sorry about that. You can go onto the website and look at your state's policy currently that is written. But this from New Hampshire really shows that they look at medical foods related to medical necessity and who can render the services. And so, and they also specify if prior authorization is required. So they're very specific in how New Hampshire writes their Medicaid policies. Versus Tennessee does say that they do not cover medical foods except for certain circumstances. In this instance, it's PKU. So what we hope to exemplify with this is it's really critical to go and see what your state says they cover. Obviously, there is case-by-case determination with any insurance program, and Medicaid is no exception. But you can go onto our website and see what your state says they cover for medical foods coverage. So another tool within the Genetics Policy Hub that we have is we track proposed legislation and regulation. So we have Molly Case, who's our project coordinator, goes in every day into a system called Fiscal Note and looks to see what policies are popping up at both the state and federal level based on specific search terms. And so we have search terms related to medical food, medical nutrition, things like that. And so currently there are 6 states that have legislation related to medical foods coverage. And as you can see on our website, you can go and click on the map, or you can click on this side area and click on medical foods to see specifically what states are proposing legislation or regulation related to medical foods. And then you can also click on any of these buttons on the side and actually read the text of the bill, so you can understand what's happening either at your state, a neighboring state, or within your region. And so again, we wanted to show you a proposed bill that was introduced earlier this year. And this is so you can find that it was recently introduced. It was the Illinois House, the bill number, and what the regulation or legislation says. And so we have a Twitter account that also publishes this information. And on the Twitter account, it specifies how this policy is related to the subject matter at hand. So this is medical foods. And so you can see what they're specifically proposing related to medical foods. And then finally, we have our policy areas. And so one of the things that NCC is tasked with doing is disseminating policy statements from national organizations. And so we had collated all those policy statements together, but we really saw that there's a lack of context when you look at a policy statement sometimes. And so within the Genetics Policy Hub, we have policy areas. And so this is the medical foods one. What it does is it gives you a very brief introduction of why this is a policy concern. It highlights legislation and regulation at the federal level that's related to this policy area. And so for medical foods, there isn't an enacted policy at this point. And so we wouldn't have anything specific. It would tie back to our tracking system for legislation and regulation. And then we list all the policy positions from organizations such as American College of Medical Genetics and Genomics, Genetic Metabolic Dietitian International, Society of Inherited Metabolic Disorders, so on and so forth. And so you can go in, you can download this as a PDF, so you can give it to somebody else, or you can go in and explore more about why this is a policy concern. And so along with this information, we also created a policy overview, a policy brief to give you an overview of what was presented today. So you can download that as well. So I would encourage you to go and download it if you want to learn more. Again, this is a snapshot. This is a constantly evolving area, as all policy is. And so this, we hope, gives you a good overview of what's happening at the national level and what we're seeing as trends. And now I'll invite Dr. Singh back to speak about her efforts to look at medical foods coverage in Georgia and the policy implications. Thank you so much.
Thank you. That was wonderful resources for us. So, okay, so we'll get back in here. You can go to the next slide, maybe. So we know, listening to this, how source of supply and coverage is very, very highly variable in each state. And this is a paper we worked, my colleague or friend, Dr. Sue Berry, who's very passionate about this topic, and worked at HRSA together. And we were able to demonstrate and confirm that the variation that patients are paying expenses out of pocket through pharmacies, hospitals, health departments, medical supply, and medical food companies. We also showed the reimbursement by private insurance can happen or not happen. Programs are administered by states, Medicaid, CHIP, WIC. There's military health benefits, newborn screening programs, or metabolic clinics, and multiple sources. So as you can see, it is very difficult, challenging for families. So this is what I tell the parents: don't give up when your insurer says no. You don't have to give it up. I thought this picture really kind of portrayed what our parents feel dealing with this. And also, next slide, please. Also, we know that that there's a lot of debate that has continued for the last 5 decades, after we have shown the efficacy of the use. Their afflicted community continues to legislate and lobby, and medical food companies, of course, are very, very supportive of getting the support for reimbursement, because it takes a lot of energy in that direction. And then we have a mixed group who are not sure at this time what they're positioning. And then the insurance industry, it depends, it's not all known, it's not yes for everybody, at least. And so the legislative debate continues, but we also know there's a lot of support of professional organization, All American Academy of Pediatrics, Genetic Metabolic Dietitian International, Society of Inherited Metabolic Disorders, and American College of Medical Genetics, all have said yes and have created statements to say we need to move on and support this effort to ensure access to medical food. So what I want to share with you is the efforts, next slide, please, efforts, what we decided to do in Georgia while all this debate is going on, and how do we kind of meet the gaps at this time. So you can click the next button, Megan. So we started the program called Medical Nutrition Therapy for Prevention program. And it has several components. It has an education arm, research arm, and healthcare services arm, both for clinical support in the clinic. But what I'm going to focus on today is the community outreach arm, what we have developed under the nutrition program. And that is the medical food access and a trained or registered dietitian support with the community outreach effort beyond the clinic. And our goals were for this program overall to prevent poor health outcomes, improve health-related quality of life, evaluate MNT for continuous quality improvement. How can we continuously improve what we are doing, and generate new knowledge in the field of IMDs, paving the way for precision nutrition. I think the goal is to make sure that none of our patients go without care if we have started the newborn screening program. And by the way, we did patent the name Medical Nutrition Therapy for Prevention for Emory. So having said that, next slide, please. So with that program, we work with our legislatures to get some funding for that little piece of medical food access. And after 25 years of hard work, we were given limited funding approved by the Georgia legislature. And we wanted to use that funding not just to give away formula. We combined our resources with our research funds and other contributions to create, we decided we'll create a national model for medical nutrition therapy for metabolic disorders identified through newborn screening, focusing more on genetic disorders which are identified through newborn screening as a starting point. And so given the limited funding, our first premise was that the insurance should pay for this, okay? And because our aim was to not let any patient go without interruptions in care who are underserved, not only in rural areas, but what I call the working poor, people who have the insurance and yet the insurance is not giving. We should not let them fall through the cracks or have any interruptions in the care. And to also, at the same time, gather point of care data to inform program development and inform the field about the need of these nutrition services, how they are utilized, and what they cost. Because when I would go to the HRSA meetings with the Medicaid directors and insurance directors, they say, give us the cost. And literally, nobody is doing research in this area to show what the cost looks like. So I thought we were in a unique position, having worked in the clinical program for 30 years, for me to kind of try to see if we can take a stab at this. So we started this research-based program with the consent from every patient and enrolled them officially in our database for the service. So we have a big, very committed, dedicated MNT4P team. And what we offer here are the services, medical foods to our patients. If they fall through the cracks with the insurance company, we give $100 to $150 voucher of low protein modified foods. And I'll talk about you the impact of that on the patients. We give dietary supplements. Many patients, I was surprised before I started this program, who could not even afford things like biotin, and know which kind of biotin to get. Insurance navigation we offer, even though social work and worker and all in our clinic should be a part of the service, but it wasn't working for medical food. So we have contracted an insurance navigator with those funds, and also the constant filter paper monitoring was a big gap, and we do that. In addition to telemedicine with CERN collaboration, as you saw, telegenetics was a big thing. And this is a picture which I take a lot of pride in, where we were able to do, during COVID, we were ready to go. Our first positive newborn screening case, 4 hours away, we were able to give both combined peer-to-peer teaching to the doctors and nurses in the outlying hospital, along with the patient education in Augusta Hospital or Macon, all the way 4 hours away from Emory. And we were able to shift the formulas. And this model actually has done wonders for our newborn screening program, to get situated, like give them the services right away to the families. And we'll be hopefully gathering data on the impact of all this and on the outcomes as we move along. Next, please. So I'm going to share with you some stories in the trenches, what we are faced with. What is MT4P teaching me, which a lot of dietitians who work with DMEs and all already know, but I think it really brings home some of the cases. Here's a 45-year-old male with PKU. He has insurance plan. It does not cover the medical foods. Coverage applies only from birth to 12 months only. So it has medical food coverage, but only for first 12 months of life. So we did insurance benefit investigations, and it said in the insurance, it covers 100%, no deductible. It's only for first 12 months though. Authorization is required, and out of network, it will cover 70-30%. Deductible will be about $250 and $900, and DME charge high amounts. So the DME for this patient charged very high amounts to the medical food. So MN24P actions that were taken, there were benefit investigation conducted on the insurance offered by his work. We could not overturn the medical food exclusion in his employer-based insurance. And so we bridged the coverage of medical foods and low protein modified foods for this patient. And when we looked at the cost, of course, ours is a bridge program and we could not continue to give. This patient volunteered and said he could afford half of that cost. So patient opted to keep the employer-based insurance despite the medical food exclusion, because we do look at other insurances and say next year you could enroll for another insurance, but he was not interested in switching insurance during open enrollment because the benefits for other things were huge for his clinic visits and all that he didn't want to let it go. And finds that paying out-of-pocket expense for medical foods were more feasible. So here, next click, please. And so this was a age-limited coverage in this example is what we see. Next one. This is a 39-year-old female with homocystinuria, Cigna, and this medical exclusion exists. Enteral feeds only, age gap at 22 years of age. Again, insurance benefits investigation showed her insurance coverage was only in network, deductible of $500, no out-of-network benefits were available, no prior authorization required, and predetermination was recommended. So what did we do for the predetermination recommended? We got that. It got submitted, and certain codes under the enteral food code feeding exclusion, it got excluded. Then it was submitted under the S code, which is under the pharmacy benefits, and prior authorization was submitted for my pharmacy, and then it was denied because the age gap. So now we provided all the documents, clinical notes, and letter of medical necessity. A lot of workforce hours go to support this service. And in most clinics, dietitians literally, I had done a survey at one time, are spending 40% of their time, instead of seeing patients, that's what they're doing letters. And these are master's level dietitians who have been trained to take care of patients. And MNT4P continues to bridge medical food and dietary supplements for this. Can you please, next, please? So this was refused due to age gap. And the other problem, what we found with this case was the betaine was not covered, the drug for the patient. And so it is also sold as a dietary supplement. And we ended up, and I can talk more about it in MNT4P. We have done some studies to show the purity of these powders from some of the companies, and verified. And so this patient is using, instead of betaine as a drug, if betaine is being used as a dietary supplement. How do we make those decisions? It's the point I'm making is it's complex, what the benefits are, how we navigate through them, and what the outcomes look like. Okay, next one, please. So the next example is patient with PKU, Harvard Pilgrim plan. This was main issue was the DME and the pharmacy looked in the network. So insurance benefits investigation showed that it covers 100% in network. Sounds wonderful. It's deductible for $5,000 before 100% coverage, and $10,000 for out of network. It's coverage diagnosis driven and requires a prior authorization. So benefit investigation was done. Pharmacy, we were able to unable to locate a pharmacy supplier, and DMI, the DME that was there, it was not even contracted with the plan. So it sounds really good what the benefits are, but when you start digging into it, actually, it doesn't get the patient what they need. So MD and dietitians are not trained to do this really, and they have to learn it as they go along for each patient. And MNDF, we provided medical food bridge. Clinic already referred to medical food company Nutricia. Nutricia provided medical food, and Nutricia sent DME referral, and provider a time for navigation, but still no solution. So again, I use the name Nutricia, but I do want to give a shout out to all the companies, Vitaflow, Advent, all these companies are very supportive and have put in plans. So look at the effort. Dietitians are doing this, companies are doing this, each company is coming with insurance navigation, social workers in the clinics are trying to do this. It shouldn't be that expensive, right? Complicated. This is another example. This is, next one, please. This is, next, please. This is a one-year-old male with glutaric acidemia who had Humana. This was covered under pharmacy benefits. However, local pharmacy did not carry the medical foods. So insurance navigation, it sounds good, 100% network in network pharmacy, which is there, only $1,000 deductible, prior authorization required for products, anything more than $750, clearly stated. And these directions are different for different insurance companies. Out of network, 3,000, and covered under pharmacy benefits. So we here look at both parents and insurance options, chose the one with both medical and pharmacy benefits. DME did not carry the product, switched to pharmacy benefits, local pharmacy did not carry the product. So NMNT continues to bring the medical foods until a medical supplier is confirmed. So this is a new parent, had no knowledge of insurance navigation. They had no knowledge of the disorder their child had. They vaguely remembered their child had a test done in the hospital, which they thanked newborn screening for. MNW4P provided all the supplies immediately. So through this program, this gap bridge program, we provided the education right away to the families, medical food access, scales, everything they needed, and did insurance navigation, and still no solution. But we in Georgia will hold their hand until they get the thing, get situated in the clinic and get the insurance company. Here is another example of a 39-year-old female, uninsured, cannot afford to pay clinic visit due to high copay, high deductible. She has tried many, many times. Despite our charity program, there have been barriers that this patient can get in. She's living by herself. She lives paycheck to paycheck. She works long hours. And part of the reasons with the paper, she has to finish the paperwork in order to even get in the clinic. And because she works long hours, she keeps missing the phone calls with the people she's supposed to meet with and make appointments. She lives 30 miles away from the clinic, and she has multiple comorbidities. Okay. She was scheduled for an appointment. We did a telemedicine around her convenient in the convenience of her home. We got her insurance navigator, offered insurance through marketplace, bridge coverage of medical foods and low protein modified fats. So you've got her all starting. She is going to revisit open enrollment with some options in 2023. We are encouraging her to take time to engage in insurance obtainment and prioritize health insurance expenditure. In the meantime, we are giving her medical food access, low protein modified $100, $150 voucher, nutrition education support with the goal to link her to the clinic. And so I've had, this is one example I'm sharing with you, but I'll tell you, after starting this program, my heart goes out. There are several women who are trying to get pregnant. I feel so joyful that we can bring them and get them in the clinic and support them throughout for good outcomes. So with that, next, please. So I think I already talked about this. Can you go to the next, please? Okay. So so I can go on and on for another hour telling you the stories about how we have using the money, working with the state with a small amount of money, how we have boosted and injected our nutrition program, both for workforce training and for medical food access. And so what have we learned? We find that families often did not know if they had caps or insurance, what the dollar amount on the cap was. Families had a hard time telling us their out-of-pocket costs. Most insurance companies do not cover low protein modified foods. WIC, I want to give a shout out to them, is a very important source for support for many families on a state-by-state basis. And we see more and more WIC patients are covered, which is patients under 5 years of age, and then when they get pregnant. Patterns of coverage vary even within the same insurance company, depending on the contract with the employer. They can have Cigna. I showed you 3 examples of Cigna coverage, and they're different programs at different companies. How are dietitians in the clinics expected to learn and understand all that? Lack of knowledge about insurance navigations, patients due to complex terminology, B code, S code. We have a full-time person who's teaching us, our wonderful friend Tammy Jones, who's become an expert in this and helps us and helps navigate our kids to get through this when the dietitians run into roadblocks. Lower premium usually equate to high deductible plan. And so it was interesting for me to review some of the data I was looking at, that a lot of these young people say, oh, I have a lower premium, I'm going to sign up for that. But those are the ones we do not cover medical foods. But they didn't know they were going to get a child with a genetic disorder. Insurance navigation fatigue by providers and patients. I have heard clinical dietitians resign from their jobs telling me they're just tired. They don't get to do as much nutrition work because they spend more time doing insurance navigation. Another group which has come to my attention, and I with several patients, which I didn't give you example, international visitors, which we take care. They can't even get in the clinic, immigrants, and some foreign students, which we are helping. Um, and I'm sure other examples will come. So these are all falling through the gaps with care. Lack of clarity in understanding the term medical foods. When new dietitians and physicians start, so I'm not sure how many really understand what this medical food terms mean and different state policies. They get so confused about foods, and patients discouraged and leading to poor outcomes in next generation. I'm worried that I see so many adult patients discouraged and it leads to poor outcomes, and next generation, I see that we'll see the impact of it despite newborn screening. And it's important for us to keep that in mind. Next, please. So what did CERN and MNT4P partnership also do during this? It's needed, and we were able to mobilize or bring all the stakeholders, including then with the GMDI, which took the role later, it created clearer messaging to patients and families affected by this disruption. It caused a lot of pain at that time. Formulated transition plan to other products based on the diagnosis. And a lot of companies stepped up to create standard comparisons, how we can substitute. And that not only saved time for the dietitians, but also resulted in much more accurate or less errors in patient, because it was a huge burden on the dietitians. So I think it's very important. The point I'm making is that the medical food is so specialized that when some disruption occurs, it even gets more exaggerated in how we handle medical foods and the policies around it. How do we kind of handle that? Next, please. So what do these cost? Next, the thing we wanted to address, and I literally see no data for policymakers to do. Next, can you click on that, please? So we look at the cost comparison. I wanted to look at the cost, and these are the low cost, moderate cost, and liberal food plans, three fundamental parts of US food guidance system that have been revised by USDA's Center for Nutrition Policy and Promotion with assistance from USDA's Food and Nutrition Service, Economic Research Service, and Agricultural Research Service brand. And what these are represented of healthful market baskets at three different cost levels, one at a lower cost, moderate, and liberal. So I decided to see how much do medical food costs related to that. Can you go back to the previous slide, please? I was talking. Yeah, this is a slide, sorry, I was talking about. So these are the three comparisons for the USDA costs, how the Thrifty plan, what the Thrifty plan is, the liberal plan is the highest plan. And I wanted to see how much next click, please. How do medical foods cost compared to this? So for the next slide, this is a cost comparison of low protein modified foods, what they cost to the patient. Can you go back, please? Previous slide. There's a slide missing of my graph. Very important slide is missing. Okay, keep going. I think that there's a slide which I would like to show for the cost. Megan, go to the next slide, please. Yeah. So this is the cost comparison of low protein food, modified foods and the cost, and they were 141% more than the real food cost. And the affected families with metabolic formulas, they're financially strained, and we give about $150 for that for those costs to our patients. And we don't have the exact cost at this time, but we're going to study the patterns, how the families are ordering these foods, and we'll be able to report for that later. Next, please. Okay, now Megan, I need to show a very important slide. I'm sorry. How can I send that, or
You can share your screen now, Dr. Singh.
I can take over to share?
Yep.
Share. Okay, let me see. I apologize. This is, I don't know if it will show on my screen. What do you guys, do you see the slide?
We do see the notes version. Yep.
You do see the slide?
Yes.
Very good. Okay, so this is a cost side, average annual cost slide, cost prescribed medical food. What we did was we took 103 prescriptions, actual prescriptions of medical food, and divided them the same as the USDA groups: adult, 18 and older, children, about 31 of those, and then in children, the infants less than 5 years of age. And what we saw on this was based on the actual prescription by the dietitians. In PKU patients only we have done this, because I saw no actual cost data calculated on the real prescriptions. And it's about 3,893 for medical food cost for infants, 10,000 for children, and about 21,000 for adults. And then on the right, you see medical food plus low protein modified food cost two together. So the cost would be around $24,744 if we combine. And there was no difference in low protein modifieds in age groups, because what was interesting was we allow $150 voucher. And so all the three ages were using all of it, about the same cost price per year. So if we were to go to policymakers and they wanted in the state to say what the cost was based on, and this cost is, the price we used was actual prices which are posted for institutional price plus a 50% markup. So these are with the markup prices. So these are very real prices, what the cost actually would be. So the cost is about $24,744 a month. So you see the PKU medical food cost plus low protein foods is nearly 3 to 4 times the monthly cost of the USDA liberal plan. So I think we will publish this data now as we move forward and add more for other disorders too. But this is a beginning, and I did want to share with you, and you could use this numbers, and I'll be happy to share them with you if you do need them for any policy issues. So the next slide is our cost, which I've already gone over, the low protein modified cost. If the patients were using this, it's about 141%. I'll now move quickly. I'm sorry, this was very important to me. But I say that this is a much lower cost than the drugs. If this is directly from drugs.com, the cost, and you can see that the drugs are 8 to 10-fold cost from the medical food, and yet they're all covered. We can afford it in this country, so I'm sure we can afford the medical food if we pay attention to that. The next one is, so I wanted to see how are we doing with our policy dilemma. We feel food at this time is a responsibility of consumer with no state reimbursement policies. They are typically covered by insurance company. We are state legislative mandates, which are all over the place. You already heard that. I don't think I'll spend too much time since I'm running a little behind. I'll just kind of mainly, these are the facts that there's a variety of different things going on, but newborn screening was started so that everyone could be treated early. Is this happening for everyone? And I want to emphasize, when I sit and reflect on my career, I say no. And it doesn't feel good to feel that at this stage. And this is going to have an impact on our outcome of our patients? Does this negate the effect of newborn screening for some despite proven benefits with interventions? I think we need to study those things. We need to see. And this MNT4P program, I think, will be at least shedding some light on we hope to shed some light on that. And I think, I know personally, both policymakers at federal and state levels recognize that the change is needed. And my question is, how do we work together to navigate through this? So 100% of our families have access to care in this country, like many other countries. There's no reason in the United States we shouldn't be able to do that. So what I did, again, I won't spend too much time. I want to acknowledge my friend, Kathy Camp. Dr. Berry and Kathy Camp are two partners in crime who have taught me a lot in this area and have inspired me. Kathy is a retired dietitian now. So I've just summarized what has happened legislatively in this field. Medical food equity act has come and gone, and I'll talk a little more about it. There's a lot of advocacy through professional organization. I think National PKU Alliance, NORD, have played a huge role. We worked on, I personally had the honor to chair the consensus statement for NIH on PKU in 2000. And also, having attended as a PI for CERN, the Secretary's Advisory Committee, they are in huge support. They wrote the letters, and the Secretary of Health, this is the last response we have in December 14, 2010. So so I'm going to click now. I have the control, so I should be doing this. It is now, as of 2023, Federal Employee Health Benefit Program now covers medical food for IMD regardless of age. So we are starting to make some progress with all this, okay? So now I want to end my talk by saying that Medical Food Equity Act of 2023 has a potential for closing gaps. It's a federal legislation requiring coverage of medically necessary nutrition for patients with specific inherited metabolic and genetic GI conditions for federal health programs. And we have precedent. TRICARE and Federal Employee Health Program for IMD as for all ages is there. And there's bipartisan endorsement. I think we all need to be educated and be aware about all this to see how we can move the needle to take care of our patients and the impact on our patients. And with that, I say, let's all stay engaged. And I use this slide for teaching medical students and my nutrition students. And I end by saying medical food is a right and not a privilege. And I personally want to thank MN214, Saran Grang, project manager, Kristen Narlow, and all the dietitians, clinical dietitians who work on our team. I want to thank everybody for their participation and helping us make this program a success. So thank you. Sorry, I went a little over. So.
Oh, it is absolutely okay. I know that we are at 1 o'clock now, so we will be respectful of everyone's time and say thank you so much for joining the webinar. If you do have any questions, please feel free to reach out to either myself or Dr. Singh. We will be posting the recording of this webinar as well as the policy brief on the hub, and so we will send out an email shortly. But thank you all so much for joining. Have a great day.